I'd like to invite Professor Vladimir, who is the president of the Slovenian Society of Cataract and Refractive Surgeons, heads the refractive and cornea services at the University Eye Hospital there, and of course the CEO of the Eye Surgery Center, which it's also a member of the ESCRS since many, many years, and examiner of the EBO Examination Board member, who is going to talk to us about intrascleral IOL fixation. Over to Professor.
Thank you very much for a nice introduction. My talk is about the intrascleral IOL fixation. And if we have no zonal support, what we do is actually all of those things. But I'm going to talk about Yamane and Calabrava technique. We know that Chariot started in 2000, and Argaval came with his good idea of gluing because Chariot had problems with the hypotony after the surgery. And then in 2015, I think, Yamane came with his fantastic technique, and then in 2018, Calabrava. So why Yamane or Calabrava? Because it's minimally invasive, it's transconjunctival and sutureless. It's just like a cataract surgery. It goes with topical, just some subconjunctival at the site of the incision, and we do just 1 3mm incision. No opening of the conjunctiva. So this is my latest technique. We do mark 180 degrees apart and then 2 millimeters behind the limbus. In young individuals, 2.2 millimeters behind the limbus. We bend first needle 45 degrees, the second needle about 80 degrees. Then the IOL is being implanted onto the iris, and the trailing haptic stays out of the eye. We can also capture or fixate the lens using the infusion. This is usually 25 gauge infusion cannula. It has to be there all the time at the surgery, and with the trailing haptic we can adjust the front haptic so that we are able to catch it later on with the forceps. Now, parallel to the limbus, the tunnel is done. It's long about 1.5 millimeters. Then we grab with the forceps. The forceps is held like that. We are not holding forceps like that, but like that. And I'm adjusting my hands. I'm left-handed, so I'm pushing my left hand towards the forceps and docking the haptic about 2 millimeters. Then, this is my innovation. This is put, okay, this needle is on a syringe. I'm taking syringe away because I'm much more precise with the syringe. And now I'm putting this onto the iris. So it's safe here, and I have to do another tunnel on the opposite side with the 80-degree bent needle, and again with the same forceps, holding it like this, I'm docking the second haptic. This surgery can be done in very small pupils, as I'm going to show later on. So docking, if you're starting this, it's good to train the docking outside of the eye. There are different lenses that can be used. In this situation, it's a sensor. And then when docking is done, we're just pulling simultaneously both haptics out of the eye. And then the flanges are done. And actually, this is the end of the surgery. So this is nearly as quick as the cataract surgery. So this is a case. I want to run through it very quickly, where it is really very small pupil. And we are able to do the technique also in such case because we push away with the needle the iris, and we are able to dock. So I'll just show the end of the surgery. Here we are making the flanges at the haptics at the end, and these haptics have to be dry when doing the flanges. We go just nearly 1 millimeter to it, and the haptics changed. And then they are just pushed back into the sclera. We could push it into the sclera, but I want to see them at the end of the surgery. This is another case. We see a heavily dislocated, subluxated lens. We took it out with the capsule, and now we are doing the same technique as you've seen before, pulling out. If we pull out simultaneously, there is very little stress on the haptic-optic junction, which I think is the most vulnerable in this kind of surgery. And now here we are taking also care of the pupil. So we are doing pupil cerclage, and after polishing it a little bit with a Gavov dialer, we have quite nice case at the end of the surgery. So here, this is 12 years after the implantation. The lens was subluxated, and I'm deciding to say that this lens stays in the eye, but I had some bad experiences, so we are laser locking the haptic-optic junction. As you can see here, this, when you have tilted lens, you can put it in the right position and laser lock it, and it stays like that. So this is another case. This is a trauma. Vitrectomy was done, and here we have decided to go for the implantation of the artificial iris and the IOL. We will use the same technique as you saw before, the Yamane, and also to put the IOL onto the artificial iris, we use the same needles, 30 gauge needles, on both sides, 0.5 millimeter away from the edge of the artificial iris, and then this artificial iris is implanted through the frown incision into the anterior chamber, and now docking of the haptics is performed on one side and on the other side, just normal Yamane technique, and then both are just pulled out in the same direction as we push them in, and we see nicely centered complex of the artificial iris and the IOL. Then at the end, the flanges are done, as you saw it before, and this is the case then at the end of the surgery. Take some time. The patient's eye, and this is the case 5 years after the surgery, working very good, looking very good. So another case I want to show you here, this is a preoperative, and here we have total iridia. The patient had trauma, and here we are going to implant the IOL and artificial iris using the Canabrava technique. So we have four 60 Prolin sutures that are put through the IOL, through the artificial iris. We are making a frown incision. Now you see this complex, and at first we mark four places, and we bring in the two 60 Prolin sutures. The tunnels should be done not perpendicular but oblique to the sclera, and then at the end we bring this suture out of the stab incision, go in again to be able to bring it out 2 millimeters behind the limbus on this side. And then at the end, we cut it away and center the IOL and the artificial iris. With this technique, you could implant also the toric IOL, maybe also the multifocal toric, but the effective lens position is very questionable. And then we push these sutures, flanges, into the sclera, so that they are just a little bit visible under the conjunctiva. So this is the case at the end of the patient. And surgical step, I think marking is very important. Tunnel should be limbus parallel, 2 millimeters, with the children 2.3, with the old, with the young man 2.2 millimeters, not to get the optic capture. And it really made this technique, my life really, really easier, because I know every patient can go from the table with the IOL in the eye, and we have all the lenses, all the diopters at our disposal all the time. And I'm inviting you to Copenhagen, and thank you for your patience.
That was really fantastic, Professor. I really thought that placing the needle on the side made the life so simple. I've never thought of this, that you can just leave it. You know, every time we're in a hurry to get that haptic out, and then someone holding on to it, or some other assistant holding on to it. But this, I thought, was a brilliant idea. The artificial iris that you're using is made by which company?
Human Optics.
Human Optics. So it does not disperse any pigment over the number of years and cause any glaucoma or anything?
No, I'm using it from 2013.
Wow.
Results are perfect. This comes with the fiber, without fiber. I'm using just without fiber, and I cutting it down to 10.5 millimeters. It
Yes,
comes
you
12.8. Yeah, I refined it down.
Yeah.
And it should be implanted in the way it doesn't touch anything in the eye. If it's touching, I don't know, ciliary body, iris, in 2-3 years you will have a problem. Cystic edema, the Huck syndrome, it's terrible then.
How do you make sure that it doesn't move? You suture it to the, how do you make sure it's placed well and always remains like that?
It won't move because it's on these sutures.
Yes.
They are stiff enough that it doesn't move. Important is only that you judge where is the effective lens position. And usually I implant the lens of -3 and leave it a little bit behind. And if it is needed, I can bring it in front. And we have interoperative OCT, so we can judge how deep it is. And also we can look if there is any touch or not at the periphery.
Now, in your country, you will have everybody with light eyes, so they normally have large pupils. Do you have control on these artificial irises with different size pupils? And
Yeah.
if you do not, and if any of them develop any retinal detachment, is it very easy for them the retinal team to manage that, or it's really not a problem?
It's a 3.5 millimeter opening, and it works very well with new systems for retinal visualization.
Thank you very much. That was fantastic.